who will be taking us through the session. Professor Emmanuel Peprah is an expert in implementation science. He is a director of implementation science for global health at New York University, the School of Public Health. And within the CCC, he provides his experience in the research working group on implementation studies. And he is responsible in leading and coordinating the technical aspects of the consortium implementation studies. And he works closely with the Sparkle CCC as well as Sparkle DCC and consortium teams and the research technical leads. Professor Emmanuel Peprah, you are welcome. And the audience is ready to listen at you. Welcome very much.
All right, thank you. So today we're going to discuss implementation research. Many utilize the term implementation science. And I believe this is going to be for maybe about 45 or 50 minutes or so. Given the broad nature of the subject matter, we're not going to be able to cover everything, but I think we can look at this workshop as more foundational in terms of at least giving you some key concepts for implementation research, including sort of the origin of the field and sort of what are examples of implementation outcomes, and explore other aspects of it. I, of course, will not be checking the chat box, but if anybody feels ready to chime in, please let me know. Mario, just a point of order. I believe at 9:50 is when we stop and do question and answer. Is that correct?
That's correct.
Okay, all right, fantastic. So moving on, you can see this is the outline, basically define what implementation research is, basically give you an example of what it is, how it's defined, give you some examples, and thinking about global health research via implementation research.
Professor Peprah, can you make a full screen, please?
Say that again.
Full screen, please. Slideshow. Yeah, full screen.
I prefer to do it this way because it helps me in terms of my just viewing. So I only have one monitor at this point. So if I was at another location with two monitors, it would be easier. But at this point, I only have one. So you have to bear with me. Can everybody at least see the slide?
Yes, we can see.
Okay, all right. So to give us sort of a foundational aspect in terms of implementation research, which many people call implementation science, we need to think about how it has sort of evolved over the years. One of the examples that I like to use in talking about the historical roots of implementation research or implementation science is the example of the utilization of citrus, specifically lime, by the British Royal Navy. So we all know what lime is and why it's important in terms of vitamin C to prevent scurvy, which is a very horrible disease. And it has been a disease that has afflicted sailors in the Navy for centuries and centuries. So basically, the British Navy observed that citrus cures scurvy in 1601. So it wasn't until actually 1747 that the first randomized controlled trial of citrus to treat scurvy was conducted. So if you're looking at the timeline, 1601 was the first observation. It took over 100 years for the first actual controlled trials to really check to see if citrus could treat scurvy. And we all know today that it's the vitamin C component of citrus that's very important in terms of preventing scurvy and other diseases. Yet, when they had the data for this showing that scurvy was actually very curative, for citrus being very curative for scurvy, the British Navy did not adopt routine use of citrus to prevent scurvy until 1795. So that was almost 50 years later. So the question becomes basically, if you have the evidence, why does it take so long for you to implement it? And that's the point of implementation science. Going on further in the timeline, in fact, implementation of citrus into British merchant marines did not occur until 118 years later. So you have one group of sailors, which is the British Navy. They had it in 1795. The merchant marines did not have it until 118 years later. So we can basically think about this from full observation, from the first observation that scurvy can be prevented by the utilization or the ingestion of citrus in sailors, to full implementation wasn't until 1865. And of course, that is a long, significant period of time. In many cases, we know that this is an important element in history because the term limey is a pejorative, which is utilized to describe British sailors. And it was basically short in the 1850s for lime juicers, because the British Navy would add lime juice to their grog. And that's how sometimes British individuals are called limeys, or in terms of this particular medical innovation. Now, James Lind, the man who helped to cure scurvy with lemons, is honored in the British, in the annals of British history. His anniversary of his birth, in terms of it, was of course documented by the BBC, as you can see here. And there's a whole institute that's dedicated to him when you visit the United Kingdom, specifically London. There have been a lot of scientific manuscripts and also some notable novels, non-historical novels written about how this sort of innovation was first discovered, was lost, and then rediscovered again. Again, thinking about that whole over 100 years or so to implement that evidence-based intervention. So this is the problem basically that we have. It's with sickle cell disease, of almost every other disease, in that if we think about it, the clinical uptake of innovations takes a long time. So basically there's a lack of uptake of clinical innovations. If we're thinking innovations, these can be innovations in treatment, technologies, for example, organizing new modes of treatment via sort of medical teams. All of these are clinical innovations. And it takes a long time for these innovations to be sort of uptake by the general society or the medical profession. As I've shown you with the example of scurvy and citrus, this is a centuries-old problem, and it has not really gotten any better. We're trying to do better, but it has not gotten any better. Our modern world, the rapid pace of modern biomedical research has outstripped our society's absorptive capacity. So there are hundreds of thousands of new innovations coming out in terms of scientific publications. How do we make sure that those are being utilized and being implemented effectively? Because just like in the case of Lyme and scurvy, when you implement Lyme and vitamin C, you not only help treat a medical condition, but you also improve the quality of life. Same for sickle cell disease. We have evidence-based interventions. How do we implement those, and how do we improve the quality of life? Over on the right-hand side are some examples of evidence-based interventions, which are non-controversial now, but again, took some time in terms of implementation. So that brings us to the point of implementation research. As I have established, it takes a long time. So centuries of experience makes it clear that establishing the effectiveness of a clinical innovation is not sufficient to guarantee uptake into routine care. We would think as individuals within the sciences, the medical sciences, data is very important and data is what we utilize, but as been shown, just because we can establish the effectiveness of a clinical innovation or an evidence-based intervention, that does not mean it will be implemented. And in fact, if you read the story of scurvy and how Lyme and the issues around how it was implemented, it's a very telling story that we, in fact, continue to encounter on a significant basis in our modern world. So the field of implementation research, many people say it's relatively new. It's been here for over 30 or 40 years, depending on who you talk to, was developed to enhance the uptake of evidence-based practices, thereby increasing the public health impact. Ultimately, we want to speed up the implementation of this so that we can have positive outcomes. So implementation science shares many characteristics with other rigorous approaches for clinical research. However, it is distinct that it attends to factors in addition to the effectiveness of the clinical interventions. So these include identifying and addressing barriers and facilitating the uptake or adoption of the evidence-based clinical intervention, whether that's at the patient level, the provider level, or at the system level. And all of those are not mutually exclusive. Sometimes when you have uptake, it could be all of those three, it could be one of those three, or it could be two of those three. So how do we define implementation science? Specifically, implementation science simply is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. So I have underlined that evidence-based because there has to be evidence for something to be implemented. So there has to be some sort of clinical evidence. We're not dealing with new and novel clinical innovations. That is on the other spectrum in which they're trying to prove the effectiveness of those. In implementation, we have, there has to be a significant knowledge base. So for example, hydroxyurea, there's a significant knowledge base around hydroxyurea. What we need to do now is learn how to increase the adoption and uptake of it in Africa and other parts of the world so we can improve outcomes. Again, for other evidence-based intervention for sickle cell disease. The second point here is the goal of implementation science is not to establish health impact of a clinical innovation. So we're not establishing, that has already been established through phase 1 and phase 2 clinical trials. But rather we're trying to identify the factors that affect its uptake into routine practice. So what are the issues that stop the adoption of this into routine clinical practice? Is it cost for some reason? Maybe we need to think about the cost factor. Is it a patient-provider interaction factor that can stop the adoption of this evidence-based intervention? And how do we work around that patient-provider element? Is this a systematic factor on a systems level in that the system just does not want to adopt it, or there's some significant impediment to adaptation on some other end? Those we can utilize implementation to sort of tease out what the issues are. So implementation is the use of strategies, just implementation in and of itself, not implementation science, is the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns within specific settings. Because at the end of the day, if you do not change practice patterns, you're left with the status quo. And if the status quo is not working for your patients, then again, that's going to be where you're at. So you need to implement something new. When we think about implementation versus clinical, this is the slide I like to use. So one of the things I say is we can go from T1 to T4. T1 or T just stands for translational phases in terms of the bench to bedside, the research continuum spectrum. So you have bench research here on the far left, which is in blue. Then you transition from whatever's discovered in basic science through clinical trials to bedside, which is sort of the clinical trials, and then to patients, and then hopefully affecting practice, and then all the way to public health. Implementation is on the further right of that field, which is more public health and practice oriented, which is the brown and green area. Clinical research is in the yellow and purple areas in terms of trying to find the effectiveness of that particular intervention. So why is implementation research so important? In the United States, this is data that we have. For us, it seems that it takes an average of 17 years in which only 14% of the new scientific discoveries enter day-to-day clinical practice. And in terms of the other quote that's very important, Americans only receive only half of the recommended preventative, acute, and long-term quality care practice. Now think about the first quote in terms of 17 years in which less than a quarter of the new scientific discoveries enter day-to-day practice. So that means that most individuals are not receiving the most up-to-date scientific discoveries in terms of clinical practices that are available. It is the slow implementation of this. Similar to the Lyme and scurvy sort of historical note that I brought before. Instead of 100 years now, we're taking at least now 17 years. You can say that as an improvement, but I think that we can improve a lot faster in terms of trying to improve the quality of life of individuals. Moreover, in terms of just federal spending, and in general, the terms of utilization of dollars, there's not a lot of money being spent on implementation research. Even within the United Kingdom, where they have an agency that's over health innovation in terms of impacting health innovation to improve population outcomes, their spending level for health innovation and implementation research is a little bit higher than the United States, but it's not significantly more. When we think about research, we can think about, as I've stated, there are different areas in terms of the translational research spectrum. Translational research spectrum contains, for example, T0, T1, all the way to T4. T4 space being sort of that public health practice space is what we call translation to real world, which is depicted here in the blue. So that is the dissemination and implementation space that we're working in, because ultimately, everything you've done fundamentally from the green to T0 to T1, which is the yellow, to the orange, T2, phase 2 and 3 clinical trial, to T3, which is clinical comparative effectiveness studies. All of those studies are not important if you cannot disseminate and change practice, because that research just sits on a shelf. And again, people just receive the same type of clinical interventions that they've been used to instead of new clinical interventions that can impact their lives. So ultimately, that T4 space is where my lab sits in terms of the IC lab. And that's where my work in terms of both sickle cell disease, HIV/AIDS, and obstetric hemorrhage in terms of maternal health lie in terms, because that's where you, in my opinion, move forward in terms of saving lives and having a significant impact. So, implementation research. As we've stated, implementation research does not look at trying to examine the effectiveness of something, but trying to see how we can have greater adoption of an evidence-based practice in real-world settings. So that means we have to work with various stakeholders. It's multi-layered in terms of we have to work with communities, providers, patients, healthcare systems, depending on the level of intervention. It's multifaceted, requires several layers. And then again, it engages so many stakeholders. And ultimately, I think the last point is important. We are trying to achieve public population level impact in terms of the work that we do. So implementation outcomes. So the box on the purple, the dark purple on the far left here, discusses the implementation outcomes. There are 8 implementation outcomes in which we are always looking at, which is acceptability. Is that intervention acceptable? Adoption. Adoption is what we look at a lot of times in terms of looking to see if our individuals adopting our systems, providers, patients adopting evidence-based interventions. Not only are they adopting it, the last one on this list is sustainability, is that evidence-based intervention being able to be sustained. Because again, if you adopt a practice and if it's not sustained, then you're back to the status quo. So sustainability is one of the things. In terms of looking at interventions, the other important elements include cost. For example, we can analyze implementation cost, which is how much does it cost to really implement this evidence-based intervention within this particular setting. And then we can think about the actual economic cost. So in terms of cost, you want to make 2 sort of specific arguments. The implementation cost versus what is being done now, because usually there's a cost savings. Even if there is a little bit more of an implementation cost, in the long run, patients have better outcomes. So usually your costs decrease. And then, of course, these other implementation outcomes, penetration, fidelity, feasibility, is that intervention feasible within that setting? Appropriateness, is that intervention appropriate for that setting? And then there are, of course, service outcomes and patient outcomes. So one example of how we utilize these outcomes was in a manuscript we published, my group published, which was looking at the implementation of the therapeutic use of hydroxyurea for sickle cell disease management in resource-constrained settings. And we did a systematic review here. And in that systematic review, we looked at, number 1, table 1, including all the implementation outcomes, and also the service outcomes, as you can see, and I'll discuss that later. So one of the things that I like to always discuss in terms of implementation outcomes is utilize this example in terms of blood pressure control associated program and a large hypertension program. And this is an example from 2013, published in the Journal of the American Medical Association. This is the figure that I always like to draw people's attention to. So as you start with 2001, sorry, and it goes to 2009, there are 3 charts here. There's Kaiser Permanente, Northern California. There is the national average, and then there's California. So Kaiser Permanente, Northern California, is a system within the United States, which is based in the state of California. They wanted to increase hypertension control. As you can see in 2001, in the circle, less than 50% of their patients were on medicines and their hypertension was well controlled. We all know that hypertension, unfortunately, if it's not treated, leads to very, very negative outcomes. So for a medical system, if you want your patients to do well and not have long-term medical outcomes, including target organ damage, you want to make sure that they are able to control their hypertension. It's a medication that they take, and then you have to make sure they titrate it and they are able to maintain that control. So within 2001, you can see that 50% of Kaiser, less than 50% of their patients were controlled, hypertension was controlled. They were actually doing worse than California. California's national average was around 55%. Over the past 9 years, Kaiser Permanente was able to increase the number of patients whose hypertension was controlled until they hit around 80% in 2009. This was far higher than California or the national average, which are both at 69% and 64% relatively. So the thing about hypertension is there's a lot of medications that we know that can work. So the evidence base is there. So how did these authors show that they were able to reach 80% of their patients having controlled hypertension? Well, what they did was basically 5 things. And this is where the implementation comes in. They first developed a system-wide hypertension registry. So you need to follow the individuals who are hypertensive. So with sickle cell, again, registry, so that you have an idea of who have sickle cell. They started reporting their annual control rates and were paid very close attention to that. So they started collecting specific data. They developed an evidence-based practice guideline in 2001 and an algorithm to show, depending on how people were doing, you will switch to this medication or that medication. In addition to that, number 4, they also instituted medical assistant visits to follow up measure. So all medical centers developed a medical assistant who would follow after the visit 2 to 4 weeks to see if medications needed to be adjusted, see how the patients were doing. That was very, very important in terms of getting to their hypertension control rate. And then finally, number 5, they made the utilization of the pill or very, very easy in terms of a single pill combination therapy that they utilize. So all of these combined was what allowed Kaiser Permanente to achieve that 80%. So again, it's not one thing, it's a myriad of things that are combined that allowed the changing of practices within the Kaiser system that allow them to reach an 80% hypertension control rate, which gives them positive outcomes. Unfortunately, again, in terms of, even though we saw some increase in California, the national average, as we can see, went down. So in terms of implementation research, I talk a lot about evidence and evidence generation. In terms of the evidence generation, that is the source that underlies implementation research. So I've shown you that it takes at least 17 years in terms of translating evidence into practice, in which only 14% or so of the American public only gets about 14% of the evidence-based interventions. That is based on sort of the United States definition. When we look at and examples from the UK and the United Kingdom in terms of their implementation, and this paper was published in 2015, they show that there are in fact significant gaps in terms of discovery to full implementation. And these researchers, Henny and colleagues, looked at, for example, a pharmaceutical intervention, amlodipine. It took 23 years for that to be fully implemented within the United Kingdom system, and so forth and so on. And in fact, if we look at examples 4A and 4B, smoking reduction, that took 39 years, and smoking reduction in terms of some of these public health interventions. So depending on the evidence, there's a significant gap in terms of translation. This gap in terms of translation of that evidence into practice exists because there are several different steps within that translational pipeline. As a researcher, we have to get grant funding, we have to publish. Those publications go into guidelines, and then those guidelines are then distributed by societies, and then we hope that those guidelines will then inform practice, as you can see at the far end. That entire pipeline is a long and significant pipeline. And as I've shown you, sometimes it takes 17 years, sometimes it takes less. So when we think about the evidence that needs to be generated, what we can do is we can have a more rigorous way of doing systematic reviews. In my lab, we have done systematic reviews, and we have developed a methodology for conducting systematic reviews on implementation research outcomes. This adheres to the Institute of Medicine general standards that you can see. Here's their standards for systematic reviews. And this was the paper that we published in 2022 last year, discussing specifically our tool that was supporting systematic reviews in implementation science communication. A couple of the publications that we have done in terms of looking at the evidence specifically for hydroxyurea for sickle cell disease management, because we felt that before we could really move forward in terms of doing an implementation project on hydroxyurea, we had to look at the evidence to see what were the implementation outcomes that were conducted in resource constrained settings. Our systematic review, and you can read this paper, we basically looked at the cited literature. We looked at for 782 non-duplicative citations. We screened them for articles of interest. We came down to 35 articles that were retrieved after text and abstract screening. After that, we did further screening. For example, we found that 32 of those articles were the wrong study design, the wrong outcomes, wrong setting, not being in resource constrained, which we utilized the World Bank standards for at that time, and then were of course the wrong intervention, did not have hydroxyurea. So essentially, if we think about the studies, there are basically 3 studies that we found that looked at sickle cell, the utilization of sickle cell disease. I'm going to show you this chart first. So this chart shows that the 3 studies, 2 were in Nigeria and 1 was in Jamaica. And in fact, they were both were in, the settings were hospital, 2 were in hospitals and 1 were in clinics. They were cross-sectional, 2 were cross-sectional, 1 was a cohort. And when they looked at their different definitions of implementation outcomes, some studies, all the studies looked at adoption, some looked at cost, and only 1 actually looked at acceptability in terms of implementation outcome. So in terms of it, we could basically gear that in terms of thinking about the implementation of hydroxyurea in resource-constrained settings, there's not a lot of research that had been done in that particular arena. And this was before the Shalolo paper came out. So again, there is a significant amount of knowledge gap in terms of how do we really implement hydroxyurea in a sustainable manner in resource-constrained settings. And those are the questions that we are trying to hopefully answer within the next few years or so that we can have a sustainable uptake of that evidence-based intervention. Because if we cannot have sustainable uptake of an evidence-based intervention like hydroxyurea, which we know is very, very effective, then again, we're not going to have those outcomes at the end that we want in terms of improved outcomes for patients. In the context of Africa, there are a lot of new and innovative therapies that are on the horizon, but hydroxyurea is still one of the most effective evidence-based interventions, therapies that are available, that is relatively cheap to implement. But we have to make sure that we implement it wisely, because again, we all know that hydroxyurea requires clinical monitoring and can have some significant side effects. And then there are some individuals that are cannot tolerate hydroxyurea. So again, in terms of thinking about implementation, we need to really think about the broader in terms of how we can really implement and sustain a hydroxyurea sort of implementation program for most of Africa. So with that, it is by my clock 9:48. We can always follow up and we can talk more in terms of implementation research, specifically at a later workshop. But I am going to end right now and ask if anybody has any questions. So thank you.
Yeah, thank you so much, Professor Peprah, for enlightening talk about the implementation science. I'm sure this has really opened an eye for most of us. And I would like now to use this opportunity to invite the audience for any questions. Any questions?
Well, I guess the talk was very self-explanatory and everybody understood. So not having any questions means everybody understood.
Yeah, thank you so much, Professor. And anyone with questions, please raise your hand or in the chat box. No questions means everything is crystal clear. This was a really great presentation. Thank you so much, Professor Peprah.
Well, thank you. Is there, Mario, over to you in terms of the rest of the agenda.
And we only had the presentation from you, and we did expect that then there could be some discussions from the participants in terms of the questions and answers. But the way I see it is that is very clear, and we don't have any questions. So I think we can just end it here.
Sounds good.
Thank you so much. So I take the audience back to Josephine, if they have anything for the skills announcement. Welcome, Josephine.
Thank you very much. Thank you, Professor Peprah. Thank you, Dr. Bruno, for being able to facilitate this webinar. And thank you to everyone who has managed to attend to this webinar. And we would like to tell you that we'll be sending the feedback forms to you all later on in the day, and hopefully we'll get some good feedbacks from you so that we can actually perfect the coming webinars that we're preparing for. Having said all that, thank you all on behalf of Skills Development Working Group for Sickle in Africa. Thank you. Bye-bye.